Good morning. Hi, my name is Angie Murad. I'm a patient educator here at the Cancer Education Center. We're glad you're able to join us for this live webinar titled Get the Skinny on Skin Cancer, What You Don't Know Could Kill You. And this is presented by Dr. Jerry Brewer. And I also wanted to mention too that I have Janine Kokel here joining me, another colleague of mine. She'll be helping navigate with questions. And we want people to know that this webinar is being recorded. For those who are not able to join us can see the recorded webinar. And also those who are joining us right now, if you want to watch the video at a later time, just to review the information, it takes about a couple days to be edited by our media services. And we put that on the video library on our cancer education blog on Mayo Clinic Connect. Just to give you some background, Mayo Clinic Connect is a digital platform that we use for patients, family members, and caregivers to connect with each other. So our Cancer Education Center has its own blog, and on that you can get evidence-based information, education information. So we will put that link, live link in the chat, and we encourage you to follow our blog so that you can stay up to date on any upcoming webinars and those educational opportunities. You can also find other upcoming webinar topics and in-person classes as well as virtual classes too. So we will allow time for questions and answers at the end of our presentation if time allows. If we get a lot of questions at the end and we're out of time, we will send those questions to Dr. Brewer and we can post them on Mayo Clinic Connect. But we will be monitoring the chat for questions. So now it's my pleasure to introduce our speaker for today's session, Dr. Jerry Brewer. He has been a member of the Mayo Clinic staff since 2009. Currently, he serves as the Micrographic Surgery and Dermatological Oncology Fellowship Program Director. He is also a professor of dermatology. Dr. Brewer's areas of interest include cutaneous oncology with a focus on melanoma, vein surgery, and hyperhidrosis. Dr. Brewer has received numerous awards, including the Penfield Award as a fourth-year medical student, the Mayo Brothers Distinguished Fellowship Award as a graduating resident at the Caris Award, and the Caris Award in 2012 by the St. Mary's Hospital Sponsorship Board in recognition of exceptional performance in demonstrating Mayo Clinic's values. Dr. Brewer's interests outside of medicine include running. He's successfully completed 4 marathons and a few half marathons. He enjoys cooking. He's an avid fan of Bon Appetit magazine. He's coached soccer, which he's done for the past 11 years now. And he enjoys Taekwondo, and he is currently a 2nd-degree black belt. And he has provided medical care on humanitarian missions, and 3 of those medical missions have been to Guatemala. And he also enjoys spending time with his wife and 7 children. So I'll now turn it over to Dr. Brewer for his presentation. Thank you so much.
Thank you, Ms. Murad and Ms. Kokel. Really an honor to be here. This is one of my passions. I just love talking about skin cancer, and I'm just honored to be here with you today. It's been kind of fun navigating the virtual world, and I have this poll everywhere slide that if there are people on the webinar that would like to interact, there's a few interactive slides throughout this talk. And if you'd like to interact, the way that you sign up to do that is you text Jerry Brewer 538 to the number 37607, and then you should get a response back to let you know that you're in the chat or in the poll. And then when we get to those slides, it should receive your text from your cell phone. And I wonder, Ms. Murad, if we should put that in the chat, or maybe I can just wait here for a few minutes to just give people a few minutes to get tapped into that.
Sure, I will do that. Thank you.
Great. Okay. All right. Okay, so I'll go ahead and move on, but if I need to go back to this slide, if anybody's still needing that information, let me know. I have no disclosures. I would like to acknowledge the Dermatology Foundation. There is a couple of slides that I'll probably reference the relationship between lymphoma and skin cancer, which is a really interesting relationship. And early on in my career, I was very fortunate enough to get a support grant from the Dermatology Foundation to do some research in that arena. And so I really do need to publicly thank them for their gracious support of that part of my career. I wanted to start out with just a few icebreakers and some questions I get commonly asked as a dermatologist, myth versus fact. So we'll see if that poll everywhere works here. So the first question is, let me see if I can, let's see, we'll go back here. So as you answer, this should kind of reset. But so the first question, do cucumbers prevent aging? So far we have 100% as myth. Maybe that's biasing people. Okay, and I don't think we're getting too much more response here. Okay, so that is a myth. Cucumbers do not prevent aging, but they certainly do feel good on your eyes, I guess, if any of you do that in spa treatment or whatnot. How about lasers can make you look younger? Yeah, quite a bit on the fact side, and the majority of you are right. Yeah, lasers can actually help you look a little bit younger. The key laser that is the most aggressive laser that we use in dermatology is called a CO2 laser. That's a very aggressive laser that destroys the top layer of skin. And it's a tricky laser, especially around thin-skinned areas like the eyelid, because it can cause scarring. So if you do venture down this path of getting a photo rejuvenation session done by laser, you just really need to make sure you're having somebody that's got experience and knows how to navigate those thin skin areas around the eyelid especially. But it can, when done correctly, take some wrinkles away, and the thought is anywhere from 2 to 5 years off of the way you look, and that's supposed to be a permanent change. Okay, so how about the next thing? Is there such a thing as permanent hair laser removal? Okay, yeah. All right, so technically no. If you look at how hair laser removal works, and in the textbooks that the residents study in dermatology, the correct answer, the board answer is that it shouldn't be permanent. But I can tell you anecdotally, if you have the right person with really dark hair and fairly light skin, which is what allows which allows the laser to really latch on to the pigment of the hair and deliver that energy all the way down the hair follicle, we have seen what appears to be some permanent effects after hair laser, but it typically does require quite a few sessions to get to that point. Okay, what about I can prevent stretch marks and get rid of them if they develop? All right, so it looks like we're all on a myth there. So, really you can't, unfortunately. I wish I had a better answer, but a lot of stretch mark development and progression is mostly genetic. So you can thank your mom and dad for that. The other, they are hormonally driven too. So a lot of times pregnancy will drive stretch marks, but I wish we had something to really get rid of them, but we really don't have a magical eraser. There are some things that can help them look a little better. If they're really red in the inflammatory part of things, there is a laser called a V-beam laser that can get rid of that redness, but unfortunately there's not really anything that can get rid of them. All right, what about, is there such thing as a scar removal cream? Yeah. Okay. And there are, there are some creams out there that I've heard people just swear by that really do a good job of smoothing and softening scars out and really making them look um, a little bit less apparent. The technical answer is no. Once you have a scar, if you look close enough, you're always going to be able to see a little bit of that scar. There are a lot of ways we can make scars less noticeable. And the common cream that's talked a lot about is Mederma. Mederma can soften the scar out when it's kind of in that what we call contraction phase, when it gets really firm during the first couple of months. There isn't really any good studies, any good head-to-head studies, so it's really hard to know how much Mederma helps versus just letting the scar mature on its own. But there are some anecdotal reports that some of these creams really do a good job. All right. Are there creams that can get rid of spider veins? Okay, and unfortunately, no. There aren't any creams that can get rid of spider veins. Spider veins are pretty common. The most common treatments that we do for spider veins is sclerotherapy, where we actually inject a little soapy solution right into the vein. The soapy solution eats away the inside lining of the vein that then scars down, and then you just can't see the blood inside of the vein anymore. And that works really well most of the time. A lot of times people need to have a good number of sessions. A lot of times it's not just one session and they're all gone. Sometimes you need to have touch-up sessions. So the average is around 3 to 5 sessions to get the veins to where we want them to be. The other option for spider veins is laser therapy. They're the most common laser. Well, I guess there are a number of lasers that are commonly used. The two of the most common lasers are called the V-beam laser and the long pulse and the YAG laser. And those lasers are really efficient at zapping away blood vessels. There's kind of these interesting YouTube videos that you might see where there's a red balloon inside of a clear balloon, and they zap the balloons with a V-beam laser, and the V-beam laser goes right through the clear balloon and pops the red balloon. And that's just because that laser it focuses on the red pigment, and so technically what that's supposed to demonstrate is it leaves the outer skin alone and doesn't damage the skin, and then goes through the top layer of skin and pulverizes the blood vessel once it hits that red pigment or that red color. All right, so the rest of this talk outline, I want to touch a little bit about some keys of how to have healthy, beautiful skin. We'll talk a little bit about common questions I get, like laser resurfacing. We'll touch just briefly on fillers and Botox. And then the bulk of this talk after that is we'll focus on skin cancer. I don't want to cause anybody to have post-traumatic stress over this. So I'll pull the audience when I get to those cases. I do have some cases to show about skin cancer. We'll kind of see if anybody in the audience is queasy or not. And then we'll kind of proceed if at that point, and then we'll end with some questions and answers. So key to healthy skin and beautiful skin. Here are my 10 commandments of beautiful, healthy skin. So things that will really help your skin be what it can be: moisturized daily. The skin really does well if it's moisturized on a regular basis. And we have our in moisturizer in our sebaceous glands, which keep our skin moisturized regularly. But sometimes, depending on where you live and the time of the year, your skin can really start to dry out. And so using a gentle moisturizer every day can help. Sunscreens are a biggie. So, I'll get to this a little bit later in the talk, but the major thing that causes our skin to age is the sun. And so just the habit of putting on a little bit of sunscreen every day, when used over a long period of time, can have a huge impact on how your skin ages over the years. There's this book that I'm fascinated in recently by James Clear called Atomic Habits. And I have no stock in that book, but it's just a fascinating book that talks about these little things we do that over time, consistently done, makes a huge impact. And sunscreens is one of those things. And so to kind of hit both of these at the same time, a lot of people find a moisturizer with a little bit of sunscreen built into it, and then you get both of those done at the same time. A little gentle cleanser daily is a helpful thing. If any of you happen to be struggling with acne, I commonly get asked, am I just not cleaning my skin enough? And the answer is no. Acne is another thing you can thank your parents for. It really has more to do with your genetics than than the cleanliness of your skin. So, in fact, if you scrub your skin too much trying to clean it, it can actually make acne worse and irritate those hair follicles. So just a little gentle cleanser daily is all you need. Don't smoke. Smoking does a really big number on the health of our skin, and in fact, can increase chances of skin cancer. Eat healthy foods. There's been interesting studies done that food that's high in saturated fat has actually been tied to actinic keratosis and squamous cell carcinoma development. And that's kind of one of those interesting things. It's hard to know exactly the connection, but there's been a little bit of a tie there. So that gets on into number 6, limit fat intake. Don't get sunburned. Sunburn is a big kind of has a big impact on how the collagen and the elastic fibers in our skin develop or mature or stay healthy or not. And when I'm doing skin cancer surgery and looking at skin under the microscope, I can actually tell how much sun a person has gotten by that second layer of skin, and you can kind of by how much collagen has been degraded. So, really try to limit how sunburns if you can. Vitamin A cream is been used for many years now, and I'm a big fan. The most common forms of vitamin A is retin A or differin. They are also used as an acne cream. Interestingly, vitamin A can have an anti-cancer component to it. And when we take high doses of vitamin A, a form of a medication called acitretin, that's actually something that we use to really decrease the number of squamous cell carcinomas that we see, especially in immunosuppressed patients like transplant patients. And so technically a cream form of that should help with at least precancer development. And we think that's true, but you just have to be consistent with it and use it over many, many months. So it has a little bit of an anti-aging property, potentially a little bit of an anti-precancer formation property. It's deactivated by the sunlight. So people who do get into using vitamin A on a regular basis, it's a good nighttime cream to put on before you go to bed. No tanning beds. We'll talk a little bit more about that. And then the final thing is you just got to pick good parents, because unfortunately a lot of how our skin goes and matures is genetic. So there you go. The 10 commandments. Moisturizers. There's really no moisturizer that's better than the other ones. There's really no good studies that prove that the really expensive ones are way better. So, there's a skin industry is a big business, and you can find, if you look hard enough, crazy expensive creams out there. And I would just say, there's really no good evidence that they work any better. So, the main thing is finding a cream that feels good to you, smells good to you. And, if that happens to be one of the cheap ones, that's totally okay. Sunscreens, there are tons of sunscreens out there, and these have evolved over the years. It used to be that you really had to make sure that the sunscreen protected from both UVA and UVB. Nowadays, just about every sunscreen does protect from both of those. I would say at least an SPF of 30 if you can, although an SPF of 15 is better than nothing. Oil of Olay Complete, again, I have no stock in any of this, but I've heard that a lot of people like Oil of Olay Complete. It's got a little moisturizer in it, a little sunscreen in it. It seems to go on and it doesn't feel so goopy afterwards, but there's tons of others out there. Neutrogena is a really great product, and there's a lot of other ones you can choose from too. So let me just touch on a couple of common procedures before we get into the skin cancer component. Laser skin resurfacing. We talked a little bit about this. This can really affect the type of wrinkles and how obvious the wrinkles are. And there's a lot of pictures you'll find out there, some crazy like before and after pictures. And it really can, if done in the right way, really kind of rejuvenate your skin. You have to be careful though. And what you don't see when you're looking at these pictures is what the person looks like right after the laser session. I mean, it's basically the laser is taking off the top layer of skin. So there is a phase where it's like road rash and really tender and really red and really raw, and the redness can stick around for months. And so that's something you really have to kind of be aware of if you venture into this sort of thing. And again, just really be careful that you're having it done by somebody who's careful up around the eyelids. That's one of the more common areas that can permanently scar if you have too aggressive of a laser resurfacing procedure done. Chemical pills. I usually don't mince words when I talk about this with patients. What a chemical pill is basically putting acid on your skin and letting the acid eat away the top layer of skin. It works kind of like a laser. The laser destroys the top layer of skin, whereas the chemical pill eats away the top layer of skin. So done in the right hands with somebody that's confident, you can have some pretty good results with this too. If you look into some of the literature about there's all sorts of definitions of what is beauty, and what society has evolved to what is felt to be aesthetically pleasing in society's eye. And one of the things that's talked a lot about in the plastic surgery literature is symmetry. One half of the face looking similar to the other half of the face, and not very many colors. So, as we age, we tend to get these little sunspots starting to appear. And the more colors that appear on our face, for some reason, even unconsciously, it kind of is looked on as something that looks more aging in a person. So if you can get rid of the colors, that makes a person look a little younger. And there's a chemical pill out there, trichloroacetic acid, that's really good about kind of taking off those sunspots and making things kind of blend into more of a kind of a one color look on your face. And that does a pretty good job too. But again, what you don't see from the before and after is in the right after, in the interim of the laser, and really raw skin, really tender. With that top layer of skin gone, you're a little more likely to get an infection from staph that's in everybody's nose. And so you just have to be really careful about infections. And you can see in this picture that there was a really good job of avoiding the eyelids, and that's a really good, careful way of doing this, as the eyelids can again scar down more than other areas. And this is a picture that shows if you have a lot of kind of pigment changes, a lot of freckling from the sun, and some of those lentigines we talked about, sometimes a certain chemical pill can really even out the tone and make things look a little bit more even that way. You do have to be careful though. Chemical pills are becoming more and more available. And I just looked online this morning. There is a pill called Jesner solution, which is a fairly safe pill used in itself. You can get that on Amazon. But when used in combination with some other also very available pills like trichloroacetic acid, it turns those pills not from a superficial pill, but turns it into a medium depth pill, which can be quite dangerous if you're eating into the middle layer of the skin. And you're not quite sure how to neutralize that or stop it. And so, this is a picture of a patient that got some pills off of Amazon and unfortunately went a little too deep. She's doing fine now, but you can see some of these pills can cause permanent pigment changes, especially around the orifices, and sometimes even scarring. So, just be really careful. What about fillers? Fillers have become a big business over the past 10, 20 years. The most common fillers are Juvederm, Restylane, and Sculptra. The common theme is, if you decide you ever want to look into fillers are good from the nose down, and Botox is good from like the nose up. You can, in general, sometimes you can use Botox down there as well. Now, Juvederm and Restylane and other fillers, especially of late, a lot of practitioners have kind of ventured out of that sort of rule of thumb and use fillers everywhere on the face. The thing I would say is you have to really be careful. And sometimes people have used fillers in areas above that line that I talked about. The problem when you do fillers up on the forehead, there's so many blood vessels, and so many of those blood vessels connect, that if you put a filler in a blood vessel, it will all of a sudden block the blood to an entire segment of your face. And this is an example of a very common side effect that we see if someone has a filler placed on their forehead. You can almost have that whole area of your forehead start to die. The crazy stories that you hear about fillers is if you're injecting the fillers up around the forehead and the eye, there's what we call retrograde blood flow from blood vessels that go around the forehead and back behind the eye and connect with the eye vasculature. And the reason that is very scary is if you get a filler in that blood vessel that goes back and then blocks the blood vessels to the eye, then it will make you go blind. And there's some crazy stories. The one I've heard recently is, I don't know if this is true. This is just what I kind of word of mouth. So you kind of know how those are maybe true, maybe not. But one story I've heard recently was a live demonstration in Brazil where a dermatologist was demonstrating that fillers were theoretically safe on the forehead, and he was injecting his wife, and she went blind in front of a huge audience right there. And so, be very careful. And I would say it's probably not a good idea to have fillers anywhere up near the eye and forehead. All right, Botox. What can Botox do for me? Botox we think of a lot for decreasing wrinkles, and it is used a lot for that. Is probably also used just as much or even more for sweating. Botox has really revolutionized how we think of hyperhidrosis or increased sweating. Now, you think, for those of you who may not have to deal with increased sweating, you think of that and you're like, and that's probably not too big of a deal, but it actually is a big deal. There was a study done that looked at all of the crazy things we deal with as dermatologists, and you can imagine rashes like crazy, people who wake up and leave a scale trail behind them, and just really impactful. Of all the rashes and skin conditions we deal with, hyperhidrosis has the biggest impact on life, on people's quality of life. And, so it is a big deal. It makes people subconsciously aware. People are a little less likely to date. It's really hard to like do well in school if your paper and your pencil's always wet. So it's, and it's hard to like do well in the business world if you're constantly sweating through your business attire. So it is a big deal. And Botox can just shut down those sweat glands immediately. The downside is it doesn't last forever, but it usually lasts for 4 to 6 months, and it can make a big difference in some of these people that have to deal with increased sweating. And you can see this is a college student that was demonstrating to me that just how hard it is for her to do her schoolwork, hold on to a pencil, and Botox can really change these people's life. Okay, I'm going to switch gears a little bit now and talk about skin cancer. And if there's any questions about that first half, feel free to send a question in the chat, and we can talk about that as much as people would like. So skin cancer, I'm gonna go through a little bit of an introduction, then we'll talk about the 3 most common forms of skin cancer. So the sun, is it good or bad? And I get asked this question a lot, and the answer is yes, it's good and it's bad. The sun has a lot of good benefit, and we're here in Rochester kind of feeling the benefit of the sun when we had like a sub-zero day on Monday, and then it warmed up quite a bit yesterday, and it just kind of gives you a sense of well-being. And I've shared this picture through quite a few talks in the past, but this kind of cracks me up. I took my family to Washington, D.C. over spring break a number of years back. And my son, who's in this photo, as we were standing in line to go into the Holocaust Memorial Museum, he managed to find, on a kind of a cool spring day, the only slit of sun kind of shining through the overhang. And you can just see his reaction to finding that little slit of sun. And that's kind of how we are as humans. We love that kind of warmth that the sun gives us. And it just adds to our well-being. And so well-being is a big topic nowadays, especially in the medical training world. And so we think a lot about, and I kind of joke around and I say, we really don't see people who are like dark seekers. Well, at least it's not talked about. If you have friends that like seek the dark, you might want to rethink your friends. But there are a lot of people that are sunbathers and seek the sun, and it just kind of really adds to our well-being. The sun is also bad, and I mentioned this before. It's what we call the major ager. Out of everything that can make your skin age, sun is the thing that ages the skin the most. It really alters the collagen and the elastin, and there's these special lights you can shine that can show you how much photo damage you have. And sometimes it's striking. With the normal light, you might not think that you have much damage, and then you shine this kind of special black light, and all of a sudden you can see a lot of sun damage. There's some fun pictures out there of like truck drivers, for example, where half of their face looks a whole lot older than the other half of their face. And in addition to aging our skin, the ultraviolet radiation has been a proven carcinogen. It is now, we've known for a long time. It's a proven carcinogen. It enters the skin and it actually destroys the DNA in our skin. And we have these really nice mechanisms in our DNA to repair those destructions when they happen. And we're usually good about doing that almost all the time. But once you have enough of these DNA mutations build up, sometimes your body just can't keep up with it. And after there's enough of these DNA damage incidences that happen, then at that point, skin cancer starts to develop. So let me just talk a little bit about skin cancer in general. There's 3 major types. There's a whole lot of other types, but 3 common types: basal cell, squamous cell, and melanoma. Around 5 to 7 million people get skin cancer. In fact, basal cell carcinoma is the most common malignancy known to mankind. More people get basal cell than any other cancer. Causes a whole lot of distress. There's surgery, recovery, scarring, increased risk of more skin cancer. It can be psychologically distressing as well as physically distressing. And the impact of skin cancer, I think is just tremendous on people taking, time off of work to get it treated, and then the amount of time and energy to treat it. The impact is just tremendous on society. Let me talk just a little bit in more detail about basal cell carcinoma. Most common cancer known to man. around 75 to 80% of the 5 to 7 million skin cancers occurring in the US every year are probably basal cell cancers. This type of cancer hardly ever metastasizes. It's extremely rare. We have seen it happen, but it's really rare. Even though this does, and so sometimes it's common, and they grow very slowly. And so sometimes it's common to kind of just let it go, and hope it'll go away. And sometimes they'll scar down over the top of it, and it will look like it's gone, but it'll eventually come back, and then it's deeper. And it can cause significant morbidity the deeper and bigger it gets. Even though they usually don't metastasize, sometimes it's very challenging to get clear margins around them if they've dove down pretty deep in certain structures, especially around the eye. Squamous cell carcinoma is a little bit more deadly. Around 200 or so thousand cases in the US every year. It might be a little higher than that nowadays. There's around a 30% metastatic rate for recurrent squamous cell carcinoma. And so the message I really hammer home to our fellows and residents is, for squamous cell carcinoma, well, for any cancer, but particularly for squamous cell carcinoma, you want to treat it right the first time. Because if it comes back, it can have a really high chance of doing bad things to you. Things that increase the chances of squamous cell carcinoma misbehaving is if it's deeper than 4 millimeters, if it's wider than 2 centimeters, if it's wrapped around a nerve, or if you happen to be immunosuppressed with a transplant, for example. Those sorts of things can increase the chances of squamous cell carcinoma misbehaving. So I wanted to show the audience some cases of skin cancer, just to give you a flavor of what we deal with on a regular basis with these 5 to 7 million people every year. But let me just poll the audience and see, anyone get queasy at the sight of blood? And I these pictures aren't too crazy, but I wanted to just make sure I'm not going to give anybody trauma. All right, well, I'm not getting anything other than the no. So if if I show anything that's like shocking, maybe cover your eyes, or you can raise your hand and I can skip or skip through a little bit quicker or stop. But let me show you a couple of cases of skin cancer. This is a patient that had a liver transplant. Having a liver transplant or any transplant, that immunosuppression tends to affect the body's ability to kill cancer. And it's true that a lot of us probably make cancer more often than we think, and our body gets rid of it a good chunk of the time. And when you do have a cancer that takes hold and grows a little bit, if you have a suppressed immune system, then it's also hard for your immune system to keep that cancer under check compared to somebody who has a very high functioning immune system. Sometimes what we see in patients with immunosuppression in particular is what we call a lot of subclinical spread, where we see where we think the skin cancer stops, but in actuality, it grows a lot farther than that, kind of just underneath that top layer skin. And that top layer skin may look pretty normal, but when we cut into it and look at it, it sure enough has skin cancer there. So this is one of those cases. This was a basal cell cancer in a liver transplant patient. In order to get rid of that, we had to take off a pretty good sizable chunk of her nose. And when you have that much of your nose gone, it's just really hard to reconstruct that, other than some pretty interesting techniques. In this case, we had to borrow some skin from the forehead, flip it down onto the nose, and then leave it connected to the forehead, so the blood vessels of the forehead keep that alive for the first 3 weeks. Then you go back and sever that connection and put everything in place, and overall things end up looking okay, but kind of an interesting way to reconstruct large defects. And then this is a gentleman that had a really kind of a deeper hole on the side of the nose. Sometimes we have to use that same technique where like the cheek is connected to the nose for a couple of weeks, and then we take down that connection later and things end up doing fine. Noses are the most common site for skin cancer. Ears are probably the second most common site. And I think it's just because those two things stick out, get a lot of sun. This is a basal cell carcinoma on the ear. And usually those do just fine. This is a really pleasant female that I met a number of years ago that had a spot frozen a number of times, which is a common way to treat superficial precancers and sometimes even really superficial cancers. But the problem with freezing is that sometimes that can cause a little subtle layer of scar to form on top of the skin. And then you have a little bit of cancer underneath there that can be camouflaged. And so this spot doesn't look too big, but when we got in there, in order to get rid of this cancer, we had to take off a really good chunk of her nose. And I talked to her about the forehead option, and she just cried. She just didn't want to do that at all. So we kind of brainstormed. We put together the top half and then put a piece of her ear on the nose as a graft. And the thing about putting a piece of skin on top of cartilage is sometimes it doesn't have the blood supply to survive. So we kind of held our breath there a little bit, but it ended up being nice and pink, which made us start to breathe a little bit more easy. And then in the long run, it ended up doing really pretty well. It kind of a little bit shiny here, but as that continued to mature, it ended up blending in really quite well. Lymphoma is an interesting thing. Lymphoma affects our immune system, and I kind of alluded that our immune system is is tied into how skin cancer does. There's a lot of forms of lymphoma. The most common type is chronic lymphocytic leukemia. For whatever reason, there's a really strong relationship with lymphoma and skin cancer. People with lymphoma have at least a 3 to 8 times higher chance of getting skin cancer. And not only that, they have a higher chance of skin cancer misbehaving. And what I mean by misbehaving, this is a squamous cell carcinoma. And I mentioned, so important to treat these, try to get it all out the first time. And, typical Mohs surgery done, margins look clear, close with what's called a V2I advancement flap up on there. The thing with lymphoma is, the crazy stories we hear is kind of similar to this one. Not only did this cancer recur, which is pretty rare to do in the setting of Mohs surgery, but it recurred very quickly and very aggressively over the course of like 4 months, and then really rapid growth 4 weeks after that. So came back and just cancer, you can just see that's everywhere kind of in the nose. And so the second go around, in order to get rid of this cancer, we had to almost take the entire nose off. And just crazy how lymphoma can affect the aggressiveness of skin cancer. Ears, you can sometimes get cancer in the crevices that's very challenging, and it can really kind of track down that the ear opening, the ear canal, and that can be kind of challenging. This is a scenario where a cancer kind of tracked down close down into that ear canal. We were able to get that out of there and then kind of grab some skin behind the ear and pulled it through the ear and closed that up. And that ended up doing really pretty well. This is a gentleman also with a liver transplant. And again, this really small squamous cell carcinoma to begin with, this one happened to have developed the ability to wrap around a nerve. Which is a very aggressive feature for skin cancer. And by the time we got rid of it, we really had to track that nerve all the way down the cheek. And he ended up doing really pretty well afterwards. Lips are also very common. The sun tends to shine down on the lips, so the lower lip tends to get skin cancer a little more often than the upper lip. Sometimes when we take out the lower lip, one of the more common closures is just to grab the inside of the lip. The lip is very stretchy, and just kind of pull it forward and make kind of a new lip out of it. This is a cancer we're not going to talk too much about. Sebaceous carcinomas are fairly rare. They can be really pretty aggressive. This is a gentleman that unfortunately had a recurrent sebaceous carcinoma that was just all over his cheek. And this day of surgery, we had to do a pretty big surgery to get clear margins. And unfortunately, this skin cancer came back and ended up killing this gentleman later. But really can be aggressive. This is a lady that had a very thin melanoma on her cheek, and you can see kind of thin and subtle and white, and that whiteness is also from previous freezing. So again, freezing can be great in the right context, but can camouflage things, including melanoma. So you just have to be a little careful with the freeze. And this was her getting rid of the melanoma, and then she did great afterwards. This is a lady that had melanoma treated with imiquimod, which again, there's all these things are good when used in the right context. Imiquimod has been shown to kill melanoma. The problem is that around 35% of the time it won't kill all of it, and if you have a little bit of it left behind, what imiquimod does is it camouflages it and turns it, instead of into a brown melanoma, into a white or a pink melanoma that's really hard to see. And so, all of this looks like fairly normal cheek, but there were pockets of melanoma hidden all throughout this cheek because it had been treated with this cream before. And this was our initial surgery, and we found little pockets throughout, and then just kept going. And in order to get rid of that, that cancer, this subtle pink area here on the picture on the left, all of that little pink area was all melanoma. And in order to get rid of that, we really had to do a huge a number on her. And I just love my colleagues in ENT. Dr. Moore happened to take care of this lady after we got rid of the melanoma, and he did what's called a cervical rotation flap, where you cut down the neck onto the chest and just really lift that skin up into place, and did a great job. I hope I didn't freak anybody too much out with that. And this is the last picture here. This is a lady that I just met yesterday that sometimes you can have basal cells really grow pretty big, and fortunately this ended up having a great outcome. We were able to get rid of that, and she is currently being reconstructed right now as we speak, and doing a great job. All right, so let me talk a little bit about melanoma. Melanoma is becoming more and more common. It's felt to have increased roughly 20 to 50% every 5 years since 1960. And a lot of cancers, it seems like over the years, we tend to figure it out, and we do a good job of promoting prevention. And the general population tends to maybe have decreases in the incidence of certain cancers. Melanoma is one of the few that continually has increased incidences as the years roll by. When I was training, this is going to date me back in like 2005, 6, and 7, and 8, the incidence number that we had to memorize was about 1 out of 72 people would get melanoma. Today it's 1 in 38, so it's almost doubled over the past 10 years of how many people are getting melanoma. And in men, it's 1 in 27, in women, it's 1 in 40, and that continues to increase. This is cancer statistics for 2021. Currently, melanoma is the 5th most common cancer in both men and women, and that has increased over the years. Incidence by location, it used to be that melanoma was most common on the legs of women and on the backs of men. Still is fairly common that we see it very likely on the trunk of men. It's kind of, the game has changed for women, and I kind of wonder if tanning beds has done this, but we're seeing melanoma everywhere in women. It's no longer just the legs. And so here's a couple of studies that kind of looked at the rise of melanoma over the years from like the past 4 decades. This is first looking at young individuals between the ages of 18 and 39. And what this study found was between 1970 and 2010, young men were getting melanoma about 4 times more often today than compared to 40 years ago. And young women were getting melanoma about 8 times more often. So then this study spurred another study looking at middle-aged individuals. Men middle-aged about 4.5 times increased risk of melanoma compared to 1970s. This is kind of what threw a lot of us off. When we looked at middle-aged women, the chances of getting melanoma today is about 24 times more likely than if you were a middle-aged woman living in the 1970s. And again, a lot of speculation as to why that is. A lot of people think that, the tanning bed industry really hit the market around the 1980s. And the majority of tanning bed goers are female, and it might just be that around 20 to 30 years are required to catch up to the effect of tanning beds, and that's probably what we're seeing nowadays. Elderly people are also getting melanoma at an increased risk. Men older than 60, about 11-fold higher increased chance of getting melanoma compared to 1970s, and women about a 4 times higher chance. So if I sum that up, the people who are getting melanoma the most often nowadays are middle-aged women and elderly men. Everybody should really be aware of their skin, but those are the 2 groups of people that we really kind of hone in on. What about mortality? 1 person dies of melanoma every hour. The good news is that it seems like the chances of dying from melanoma is getting better, especially among women. And there's a lot of speculation of why that is. Women are a little more likely to be in tune with their skin. They're a little more likely to maybe go get their skin looked at. Something about, if there's any men on the call, I apologize, but there's just something about men to just kind of like, it'll be fine, sort of that denial thing. And so this is a study from one of my really good friends in Cleveland. And he looked at this interesting finding of your chances of dying from skin cancer dependent on how many dermatologists live in your community. And he found that if the number of dermatologists that are present in a community of 100,000 people goes from 0 to 1, then your chances of dying are reduced by 35%. Isn't that interesting? And if that goes from 1 to 2, then your chances of dying is reduced by 53%. So if you happen to live in Rochester, I think we got you covered, because Rochester's like 112,000, and there's like 35 dermatologists here. But interestingly, over 2 dermatologists, there was no further advantage. But so, if you have access to a dermatologist, use that resource, get your skin looked at, and it can really be beneficial. Risk factors for melanoma. There's a lot of risk factors: number of moles, the size of the mole, although please don't use that as a kind of a way to disregard smaller moles. I can't tell you how many times I've found melanomas in tiny moles, but it is true that the larger the mole, maybe a little higher chance of it being a bad mole. If you live at a higher altitude, higher chance of melanoma. Red hair, blonde hair, about 2 times higher chance of melanoma. Lots of freckles, family history. If there's somebody in the family that has had melanoma, then your chances are 3 times higher. This is a gal that had ulcerative colitis sort of scenario, and she was on a combination of Remicade, which can suppress the immune system, and Cipro, which is an antibiotic. And for whatever reason, some of those combinations in certain people with the right genetic makeup can cause your moles to just blossom, like you've put Miracle Grow on your moles for whatever reason. And she, as you can see, just grew a ton of moles when she was on those medications, and we follow her very closely. Also, there's this thing called a speckled lentiginous nevus, which is a big mole with lots of tiny moles inside of it. And this particular gentleman, within that big mole, there were 3 melanomas inside of there. And so we ended up just cutting that entire thing out. Plastic surgery did a great job. There's also a big genetic predisposition for melanoma. This is a gal that was found to have 2 genetic mutations in her skin, both of which made her moles unstable. And so, she is one of the only people in my career where we actually did a demoling procedure, and we took off 58 moles in one sitting. And that's not commonly how we practice medicine. In her case, since her moles were so unstable, we ended up thinking that was a good idea. And she ended up having 6 melanomas. And then after we took all of her moles off, she developed some subtle changes over the years, which were very easy to track because all of her moles were gone. This was a tiny little thin melanoma that she developed on her arm a couple of years later, with no roots. And so the chances of her having any problem with that is very small. And then this was a second really thin melanoma she developed on her thigh a year after that. Also, one of the conundrums that I think about a little bit is the influence of hormones on melanoma, and it is known that there is a hormonal component to it, for whatever reason, and we haven't been able to figure that out. And there's a lot we could go into it, and I'll just touch on a couple of things. One is, if a woman, like many things in life, women tend to do a little bit better than men, and if a woman gets a melanoma and a man gets the exact same depth of a melanoma, the woman tends to have a little higher chance of surviving that melanoma, especially if they're premenopausal. And I don't think we've figured that out yet. But this is a gal that I've been following that has had 7 melanomas. She was on hormonal supplements for years, and at one point decided to stop that, and her moles tended to really stabilize after that. But this is a melanoma. You can kind of see one edge is a lot darker than the other, really dark center, and it kind of trickles off on the edge. That's what we call asymmetry. This is another one that you can just see a little dark edge, and then these little dark dots around the periphery are called pseudopods. That kind of tells me that mole is actively growing. And that was a melanoma on her as well. This, pink is a color that we really don't like that much as dermatologists. There's a sign called the Little Red Riding Hood sign, where sometimes your body is trying to kill the melanoma, it turns things pink and white, and this has a lot of colors to it, a lot of pinkness to it. That ended up being a melanoma as well. And so, what about sunburns? If you have, who of us, if we were in person, I'd have everybody raise their hand that has been sunburned before. And usually when I do this, just about everybody raises their hand. Who of us that grew up did not get a sunburn growing up? It's just really uncommon to not. But having 1 or more blistering sunburns during childhood can almost triple your chances of melanoma later on in life. More than 5 sunburns can double your risk. If you're a survivor of melanoma, then 9 times more likely of getting melanoma. I'm going to touch on tanning beds just briefly. So what about tanning beds? Is there really a big deal with tanning beds? Are they really that much of a risk or not? We see it. There's a lot of ads out there for tanning beds. Tanning beds have been now proven to be a carcinogen. In fact, they've been put into the same category as plutonium and cigarette smoking. It's not a debate anymore. Tanning beds cause cancer, and they cause cancer in a big way. So people who have ever tanned even once have a 67% higher chance of squamous cell carcinoma and a 29% higher chance of basal cell carcinoma. And one session gives that person about a 20% higher chance of melanoma. And if 10 or more sessions from a tanning bed, about a 34% increased risk of melanoma. And it seems like, we're still figuring this out, but it seems like the more tanning bed use, the earlier in life, which is usually when people go, I think around a survey that was done here in Rochester found that I think it was around 10% of 11th graders went to tanning beds regularly. But, tanning beds before the use of 35 can increase your chances by up to 75%. So, it's a big deal, really has a high chance of influencing melanoma development. This is currently the legislation. There are 19 states and DC that all ban tanning beds, and at least 44 states that have regulations in place that, like, a minor can't use a tanning bed without the approval of a parent, sort of a thing, which is good. It's really good that this is moving in the right direction. And, for any of you who are really big into behavioral psychology, which is a really tricky thing, I'm still trying to figure that out with my kids, especially, but it sounds like, some of the behavioral psychology classes that I've taken, some of the bigger influences on changing behavior is like legislation is a big one. And if you look at smoking, when some of the legislation was passed for smoking, that tended to influence smoking behavior a bit. But so I'm glad legislation is going in the right direction. This is an interesting map. The darker the color, the higher chance of getting melanoma. So, and I currently live in Minnesota, which is right there, pretty dark, kind of interesting. And in fact, it's even darker than Florida and California. So by per capita, it looks like, according to this map at least, that more people are getting melanoma per capita than in Minnesota than in California and Florida. And sometimes we kind of wonder why that is. Minnesota and other states similar, there's a lot of gray days. And there's a very real thing called seasonal affective disorder where people really get down when you go like 30 days without seeing the sun. And so I kind of wonder, I don't think there's ever been any studies to prove this, but I kind of wonder if there's a little higher chance of going to tanning beds in those sorts of states, sort of a thing. There was a really good win for us a number of years back, which banned minors to use tanning beds in Minnesota. There was a study that went out to see how many tanning bed facilities honored this. Which having this notice posted on the wall is what should be happening. And what this survey found was, about 95% knew that there was legislation in place, around 5% didn't, and a good chunk of these places had no sign available. And there's even a tanning bed facility here in Rochester that has no workers. It's just you come in, you swipe your credit card, you get a token, and then you can go in the back, put the token in, and you can use the tanning bed. And so, as you can see, even though there's a ban on minors using tanning beds, if you want to do it, you're going to people find a way. And particularly in situations like this, where there's tanning beds available, where there's no workers even there present, people are going to find a way if they really want to do it. Let me just talk a little bit about diagnosis, and then we'll end. So, we talk about asymmetry, one half being a little different than the other half, irregular border, more than one color in the middle, and bigger than a pencil eraser. Again, don't let that fool you with not looking at your smaller moles, but those are some of the key things we look at. If we're worried about a mole, we'll usually do a punch biopsy, where we take a little core of that mole off and send that to the microscope. Melanoma typically looks like this when it first starts under the microscope. This is melanoma just starting underneath that top layer of skin. Once it gets going, it'll break through that top layer of skin and really dive down deeper. The deeper it goes, the higher chance it has of spreading. So one of the key messages, if you don't remember much of anything else, is the earlier you catch something that's potentially worrisome, the better. And every skin cancer is curable if it's caught early enough. So really important to keep an eye on things, especially if they're just beginning to change. This is a very thin melanoma. Once they get going, they get a little bit bigger and darker. This is a melanoma on a young gal. Sometimes we'll take pictures of high-risk people. And the reason we caught this is because she had photos done called mole mapping, where we map your moles and kind of put it in the chart as a baseline. And this mole in and of itself didn't look too bad, but when we looked at the photos, this had increased by like 100%. It got twice as large over the course of like a year. So we took that off, and that ended up being a melanoma. This is a gal, typically it's the reverse, where her husband encouraged her to go get this mole looked at. Usually it's the wife encouraging the husband to go get looked at. So I give kudos to this gal's husband. She came in, you can kind of see again that Red Riding Hood sign, really pink, hazy border. This ended up being melanoma. Interestingly, airline pilots have about a 3 times higher chance of melanoma. This is an airline pilot. You're up closer to the sun. The UVA rays that cause melanoma can go through windshields. And this is a very subtle one, very pink, called an amelanotic melanoma. And those are kind of the scary ones that are kind of easy to disregard as maybe an acne bump or something like that. I talked a little bit about depth, and the deeper it goes, the higher chance it has of doing bad things. Prevention is the key, and this is getting close to my wrap up. I know we're getting close to time here. So the conundrum is, how do you influence behavior? And I touched a little bit about that, especially in adolescence. The younger folks, just kind of have a little bit of that indestructible kind of psyche, and it's sometimes really hard to break through that. But early management is key, like I alluded to just a minute ago. Education, sun avoidance, no tanning bed use. Mole mapping can really help in people who have a lot of moles or a lot of high risk features. Self-skin examinations are huge. And so one of the other key points is just take the time to look yourself over. And it's a good idea just to kind of get in the habit of doing that. Usually I say just find your favorite day of the month. Look yourself over. If you happen to have a partner or a spouse, sometimes this is a good thing to do together, because then you can monitor each other's skin, and your partner can look at kind of hard to see areas that you can't. And that way you're going to find things change a lot quicker than if you're not kind of looking yourself over. If you have a few high risk features, it's always a good idea to have a dermatologist look at you, and then prompt removal of anything that's changing. Primary prevention is taking things off before they have the chance of turning bad, kind of like taking all the moles off of that one gal I talked about. That's typically not how we practice medicine in the US, but sometimes we do in certain situations like hers. Typically, we practice secondary prevention, which is trying to find things as early as possible. So if something is going to turn bad, then we try to take it off as early as possible when it is starting to change. And then there's tertiary prevention, which is very challenging, which is treating skin cancer once it's already spread. I would say this is kind of a game changer. There are so many options out there for tertiary treatment that were not available 10, 15 years ago, and really the game is changing here. So my concluding slide is melanoma is on the rise, especially in women and elderly men. It can happen to you, can happen to me. Mortality is improving. That's the good news. So, maybe that means we're finding a little bit earlier. We can probably do a better job with educating our colleagues, our friends, ourselves. Influencing our youth is probably a big responsibility of ours as society. And if we can really do a good job influencing our youth, that'll probably really make a major dent in the amount of skin cancer that they deal with when they're adults. So this is my family. Took a little bit of effort to get everybody off the ground there, but I am so grateful that I had the chance of sharing some of my thoughts with you all. And I think we have just a couple of minutes for questions. Is that okay, Ms. Broder? Okay.
We're doing good. Yeah.
Okay.
I think Janine's is monitoring the questions.
Yeah, we have a couple questions while people are putting their other questions into the chat function. But to start here, we have 2 questions. Is it a good idea to use blue light blocking sunscreen?
Oh, I've heard of that before. That is a really good question. And I don't think there's a whole lot of research done on that, but I think anything that blocks any, so I guess the short answer is I haven't heard any good evidence, but I think any sort of ultraviolet radiation is potentially a good thing to block. Yeah, that's a really good question. And I need to look into that more, because I've heard that question before. Yeah, appreciate that.
Particularly eyes, I suppose, but
yeah, right.
Okay. Then another one, what's your opinion on the 4-day treatment with Effudex plus calcipotriol versus a 3-week treatment with Effudex?
Yeah, so calcipotriol or Dovanex has really kind of influenced the way we think of Effudex or 5-fluorouracil. Effudex is a chemotherapy cream. It's basically chemotherapy in cream form, and it's what my colleagues call a high IQ cream, meaning that it will target DNA damage in your skin and kill it. And so if your skin does not really have any precancerous changes, then you might not get much of a reaction. However, if you have a lot of precancerous changes, it can just eat away that top layer skin to where you look terrible, like road rash. And I think some of us have seen those pictures before. It's a little bit of a torture. And one of my other colleagues calls it tough love, because it's just, if you can imagine your skin just being raw, tender, kind of raw hamburger skin for like, the first week isn't too bad, but the second week gets bad. And then the third week, so prolonged over 3 weeks is just, and, a lot of people can't even stand to make it the whole 3 weeks. And the good news is if you make it through the whole 3 weeks, your chances of getting a skin cancer after a squamous cell type cancer after that is reduced by like 85%. So it really does a really good job of clearing up that skin. It's just the prolonged nature that's really tough for people. And so the combination of calcipotriol has really, in some ways, revolutionized it. And it makes the effectiveness stick around, but you only have to use it for 5 to 7 days instead of 3 weeks. So I'm a big fan of it. When it first got published and people started to jump on that option, it used to be a very expensive combination. And I think it's gotten to the point where insurances are covering it more and it's easier to get the combination without paying so much for it. But yeah, I'm a big fan. I'm a big fan of the combination of calcipotriol and 5-fluorouracil. It works really pretty well.
Then I guess we're getting to the end of time here, but maybe would you expand just a little bit on moisturizers and ones you would feel that would be good and something that maybe really shouldn't be used?
I'm a big fan of gentle, bland moisturizers, particularly if your skin is a little sensitive, and sometimes, especially in Minnesota in the winter, and your skin might start to get kind of that dry, kind of irritated kind of feel to it, especially if you haven't got your water softener in place in your house. And if your skin is a little on the sensitive side, a lot of those creams that have a lot of perfumes and preservatives will really kind of irritate your skin. And so I'm a big fan of the bland ones. And so there are a lot of goopy, really kind of thick creams out there, like Aquaphor, for example, is really thick and goopy. And there's pluses and minuses to that. It'll really do a good job of sealing in that moisture into your skin. But it can just feel really goopy, and some people don't like that. So, I would just say, kind of play around with it. There's so many options. And if you find something that you like the feel of, and it's not irritating your skin, then great.
Okay, thank you. I think that's all the questions that I'm seeing on the chat. And
okay.
Thank you so much. That was an excellent presentation, and I really learned a lot, and I know that was very helpful for all of our attendees.
Yeah, thank you so much. We appreciate your time today.
My pleasure. Thank you very much.
Okay, thank you. Thanks for joining us, everyone. Have a good day. Bye-bye.
Bye. Thank you.